Welcome, everyone, and thank you for joining us today. I'm Marie McKenzie, the Donor Relations Officer with UHKF. This webinar is being recorded and it will be available on our YouTube channel and on our website tomorrow. We expect the webinar to last between 45 minutes and an hour, and there will be time for questions at the end, but please feel free to enter your questions using the Q&A feature at any time during the presentation. Circle of Care events are held several times each year. Their purpose is to provide donors with a special opportunity to connect with some of our outstanding healthcare and research professionals. Today, we are very fortunate to have Dr. Sunil Patel, the Associate Professor of Surgery and Medical Director of the Robotic-Assisted Surgical Program at Kingston Health Sciences Center with us. He's going to speak about the A. Britton Smith QC Robotics Program. Dr. Patel is a fellowship-trained colorectal surgeon at Kingston Health Sciences Center. He has specialized training in minimally invasive surgery and specializes in treating rectal cancer, colon cancer, inflammatory bowel disease, and diverticular disease. Dr. Patel completed his general surgery in London, Ontario. He completed his colorectal surgery fellowship in New York City at Memorial Sloan Kettering Cancer Center and New York Presbyterian Hospital. Memorial Sloan Kettering Cancer Center is considered one of the top cancer hospitals in the world. He has also completed a Master's of Epidemiology at the London School of Hygiene and Tropical Medicine in London, UK. Dr. Patel's research interests include barriers to treatment in colorectal cancer and inflammatory bowel disease patients, the use of smartphone technology in delivering clinical care and evidence-based healthcare. Dr. Patel is also a member of the Cancer Care and Epidemiology at the Cancer Research Institute and the Regional Colorectal Cancer Screening and GI Endoscopy Lead. Welcome, Dr. Patel.
Okay, thank you for the introduction. I'd like to apologize. I know it's not great to start a presentation with an apology, but I've just upgraded my Zoom and my computer, and now I can't get my video to work. So you can see my name, but not my face, but I think everyone can see the presentation, which hopefully will be helpful. So I wanted to begin just by thanking the foundation for inviting me to come and speak to you guys today. I gave a similar presentation in the fall, and I've updated it a little bit. And what I wanted to do was just talk about the impact of robotics on surgery and outcomes at Kingston Health Sciences Center. And I've left some time at the end so that I can answer some questions, because I know a lot of people have questions and thoughts about the robotic platform and how it's impacting the care of our patients, not just in what I do, which is colorectal surgery, but across the many subspecialties. Okay. And I'll rely on Marie just to let me know if my slides are not advancing or if my Zoom starts to really crash. So please speak up if you're not seeing them properly. So just a bit of a disclaimer, I am a colorectal surgeon. So a lot of what I'm focusing on today is the benefits to colorectal surgery patients. But the benefits are the same across the specialties and subspecialties that use robotic surgery at KHSC. Many of the themes are similar, the outcome benefits are similar, and the impact on our patient populations are similar. And currently at KHSC, the urology surgical services are using robotic surgery. They do this for prostate surgery and kidney surgery. The gynecology oncology surgeons are also using the robotic platform for hysterectomies and those with mostly cervical cancers and other complex cancers. And then the thoracic surgeons are using the robotic platform to treat lung cancer. So what is robotic surgery? I've reused this picture many times because I think it gives a good sense of what the evolution of surgery is, at least as a robotic surgeon, what we think of it as. You know, we started not too long ago primarily using open surgical techniques to provide surgical care. And then there was the evolution and advent of laparoscopic surgery, which was the first form of minimally invasive surgery, and is still continued to use to this day, and is actually a very effective technique at minimizing the trauma of surgery. But robotic surgery really is the next step and the next evolution of our surgical techniques that really expands out our capabilities and what we can offer patients. Traditional surgery, as some of you on the call may have undergone themselves, is tried and true surgical technique. And for us and for patients with colorectal cancer surgery, it usually means a large abdominal incision. there tends to be a longer length of stay with this, and it's primarily relates to the trauma that happens when someone undergoes this type of procedure. A length of stay of a week or more was not unusual for those that undergo even straightforward and relatively complication-free surgery. The issue with recovery from surgery is not just to the hospital stay itself, but we do witness a pretty prolonged return to normal activities, which may include work or just regular activities, which can take several months. And again, it's the trauma of the open surgery primarily and the incision that's contributing to this, not necessarily the organ that we're operating on. Other common outcomes of this group of patients that underwent traditional surgery also included more frequent emergency department visits for things such as wound infection, or bowel blockages, or other issues related to the surgery. And then long-term, we saw a lot of issues with hernias at the incision sites, scar tissue, and adhesions, which can have their own problems. Minimally invasive surgery tries to overcome the trauma of an open surgery, which is primarily from the access incision. And these are some representative pictures of people that have gotten open and minimally invasive surgery. And I think it's pretty obvious who has the open surgery versus the ones that have the small incisions from minimally invasive surgery. And this is not unusual in someone that's had colorectal cancer. You can see the top middle picture, someone that has a large midline incision as well as an ostomy incision. Whereas the one just next to on the top left, you see these tiny little incisions that you actually have to color in with blue just so that people can actually see them. So minimally invasive surgery really reduces the length of stay and allows for earlier return of normal activities. And again, we think that this is primarily due to the reduction in the trauma that is experienced to patients as they're undergoing the surgery. We also see a reduced risk of emergency department visits or readmissions to hospitals. And in the long term, we see patients that have better cosmesis, less scar tissue, lower risk of hernias, and lower risk of bowel obstructions. And this is primarily, almost entirely, due to how we access the abdomen, whether it's through a major long incision versus these small little incisions. Robotic surgery is a little bit different. So traditionally, here are some pictures of what laparoscopic or traditional minimally invasive surgery looked like. You can see that the instruments are fairly straight. In the bottom right-hand corner, you can see that there's a number of instruments that are relatively straight with handles. And these go through ports that are made in the abdominal wall. These instruments can be accessed certain areas when it's relatively straightforward, but getting down low, especially in this bottom left where the cancer's sitting, around a corner can be very challenging. It can also be very difficult to see and work in really small places. And that's why I put the picture up in the top right that kind of shows you what type of space that we have to work in. Because minimally invasive surgery can be very challenging in this patient population, we see that the adoption of minimally invasive surgery wasn't great. This is a study that looked at the proportion of patients that had a laparoscopic resection for colorectal or for rectal cancer between 2004 and 2014. And you can see that even up to 10 years ago, less than 40% of patients were being offered minimally invasive surgery. And thus only 40% of patients were really benefiting from the advantages of minimally invasive surgery. And, it kind of brings us back to the point that minimally invasive colorectal cancer surgery can be hard. And that is really why we wanted to do robotic surgery. This is our local data from Kingston Health Sciences Center. I started at the institution in 2015. And what I've put up here is our rates of minimally invasive surgery, the rates of conversion to open, and the ones that are just starting off as an open surgery. And you can see that in 2015 to 2017, around 40 to 45% of our patients were having successful minimally invasive surgery, which improved a bit over the first 3 or 4 years that I was here, up until about 60%. But that really does mean that only 40% of patients, or still 40% of patients, were undergoing open surgery with all of the problems associated with the recovery and the long-term outcomes. When we looked at ourselves compared to our hospitals across the province, we found that we were doing a little bit better than the provincial average. The provincial average across all hospitals is around 45% of patients undergoing minimally invasive surgery. And you can see that in 2018, we were about 60%. Bit above average, but not really where we want to be. And so our motivation to adopting robotic surgery was really to help improve our minimally invasive surgery rates. We really wanted to increase the number of patients that would benefit from robotic surgery, from minimally invasive surgery, and really have those benefits of the reduced trauma of doing open surgery. We also wanted to reduce our conversions to open surgery. You saw in the last slide that although there was some attempt at, in some cases, of doing minimally invasive surgery, we had higher conversion rates than what we wanted. We also wanted to improve patient outcomes. And this, again, was a really important driver for us. We know how disruptive it is for patients to be in hospital and how disruptive it is to be away from normal activities, normal function, doing the things that you care about for months on end after surgery. And then finally, we really wanted to start to expand our minimally invasive surgical capabilities, which included doing more complex cases that traditionally had always been done open, as well as doing cases in a multidisciplinary fashion. So combined cases for patients with multiple issues. Not unusual for cancer patients to need a colon resection and then the liver resection, or have other issues that may need a colon resection and hysterectomy or other combined cases. This chart on the left, I think, is a very well-known chart that just talks about adoption of new technologies and innovation. And really, we felt that at the time when we adopted robotic surgery, we were probably in this chasm of adoption. Prior to 2019, like less than 1% of Ontario patients were getting robotic surgery, and it really was only offered by one relatively modest volume surgeon in Toronto. And we thought that we could really improve upon this. When I was training in fellowship in New York, which was from 2014 and 2015, about 80 to 90% of people were offered robotic surgery. And we thought that we needed to do better in Ontario and specifically in our region to improve this and kind of match what the Americans had already found out, which is that robotic surgery was a very effective way to offer surgical care for this patient population. So I wanted to kind of go through some of the nuts and bolts of what robotic surgery looks like. I have some pictures from the operating room and some diagrams and things that show exactly what we're talking about. So robotic surgery really is advanced minimally invasive surgery. Instruments are controlled by surgeons at a surgical console. There's articulating instruments and there's a 3D picture. And I think when we talk about robotic surgery, sometimes there's some misrepresentation or misinterpretation of what that means. The surgeon is still doing the case and is still making all the decisions and movements of the instrumentations, but instead of doing it directly through a relatively simple or low-tech tool, we're doing it through a machine that has capabilities that we can't match ourselves. This is what some of the components of robotic surgery are. So we have the patient console, and on the left, you see the diagram of the surgeon sitting at the operative console, and on the far right, we can see a picture of what this console looks like. And this is something that I would sit at, or the robotic surgeon sits at. You can see that there's a spot to put your head in and look through some viewfinders. There's the robotic surgical cart, which is in the middle, and that's what actually sits over top of the patient and controls the instrumentation. There's what's called the vision cart, which has the TV screens and has all the computers and electronics for the actual robot itself. And this is what it's connected to and what we have to interact with. This is a better picture of the surgeon console and kind of what it looks like. So you can see there's foot pedals and there's a place to place your head and a place to place your fingers. And there's a lot of different things that we can do here. There's a 3D viewer, so there's two eye viewers, and what that translates to the patient is there's actually a camera with two lenses. This gives us a 3D picture, which you do not get with traditional laparoscopic surgery. A lot of advantages to this, especially when we're working in really tight spots. You can be much more precise with a 3D picture versus trying to reinterpret the view we get from a 2D picture into a 3D image in our heads. We have surgeon controls, and this is how we control the instruments. These are finger-triggered controls that allow us to move and articulate the arms like we would our hands and our wrists. And that's what we use to move the instruments in and out, and that can control the camera. All on here, you can't really see it very well, but there's a touch screen that allows us to change the settings for the robot. We can change how fast the instruments move. We can change some of the viewing settings and who's controlling what instruments. And then there's these foot pedals, and what they are like energy controls. So you can see blue and yellow pedals. They're different types of energy that we can use, and there's left and right, meaning that we have energy attached to left and right-handed instrumentations. There's also a foot pedal to control the camera, so it allows us to move the camera in and out and really take full control of what's going on within the surgery itself. These are some pictures of what we call the vision cart. So this is the TV console. You can see the top picture. This is a touchscreen. And what it does is it allows people at the bedside to see what you're doing and what you're seeing in your viewfinder. This is for the nurses and the assistants to make sure that they can follow along. And there's some additional controls and capabilities that we have on that screen. In the bottom left, it's showing a picture of our 3D camera. You can see that it's a 30-degree camera. That's what it's showing. And there's some controls on that. And it plugs directly into the vision cart, which gives us the really good and high quality picture. On the bottom right, you're seeing some of the energy controls. That unit in the middle there controls the type of energy we can use, which is used for cutting and controlling bleeding, and also has a lot of other data that's being developed and controlling a lot of the movements of the instruments itself. Interestingly enough, there's also a microphone and a speaker on this, which allows us to communicate between myself sitting at the surgeon console and the nursing staff and the assistants. My partner, Dr. McDonald, doesn't like me to tell the story, but he used to have a rule in the OR that there was no singing in the OR while he was operating. And we used to be able, when I was helping him, and could hear him through the microphone, often singing Eagle songs during the cases. So I think he's toned that down a little bit, but it does pick up voices very, very well. This is the patient cart. So this is the actual part that sits on the patient. And it holds the robotic instruments. These are surgical ports. They're very similar to laparoscopic ports, but they're used for robotics. And these are where the instruments go through. And you can see that the arms that are attached to those ports are the things that are controlling the instrumentation. And these are kind of the robotic arms and hands. It controls the instrumentation. It moves the instrumentation as I give it instructions. This is how I would move the instruments in the belly. So you can see on the bottom right how you would hold your fingers and how you can articulate these instrumentations. So unlike laparoscopic instruments, you can't bend the wrists of laparoscopic instruments, but these you can, which really makes doing very precise movements, especially in very small spaces, quite easy. In some ways, it's actually easier than even doing open surgery in terms of the movements, because you can do it in much smaller spaces than you can regularly with typical instrumentation. This is a video I like to show as it demonstrates the dexterity and the movements of the robot. And hopefully this is coming through the Zoom meeting okay. And what you're seeing here is some robotic instruments. You can see how precisely they're moving and how they're articulating and folding this piece of paper. These are very common types of instruments that we would use. And I think this video really hones in and shows the precision that you can do. I really like this video because although that's not me, it kind of looks like me. And so when I show it, people often think it's me that's doing origami that's smaller than a penny. This is pictures of what the robot looks in the operating room. It's a lot of equipment, and some people on this webinar, I think, are former patients of mine or others, and it can be actually quite intimidating for patients when they come in the room. But this is the general setup, and this is how it would look if you walked into one of our rooms while we're operating. The top right picture, I think that's me at the console, and then we have our resident and one of my colleagues at the bedside helping out. I just want to go through a bit of the impact of robotic surgery at KHSC. And I'm trying to focus a little bit on patient outcomes because there is a lot of advantage to surgeons, but I know that this group would probably appreciate that. So robotic surgery, I think, is very unique at Kingston Health Sciences Center. The perioperative service and the administration and executive has been very supportive of us adopting robotic surgery. This is colorectal robotic surgery volumes over the years. Our first year that we came into practice, we performed about 65 cases. This year, we're on track to perform more than 150. And I actually think that this is an underestimation now. I think we're on track to perform about 180. Our original goal was about 70 cases a year based on just a number of different metrics. But what we recognized very early on was that it was such a benefit to patients, their outcomes and their recovery, that we didn't want to limit it. We wanted to offer robotic colorectal surgery to anyone that was eligible and anyone that we thought was beneficial. And so the hospital is very supportive of this. In a lot of centers, there's concerns about certain costs or even access, as there's a lot of groups trying to vie to get onto the robotic platform. But we were very fortunate to be able to grow our program. We expect that this growth will continue, and we think that for patients with colorectal diseases, we'll probably be performing more than 200 procedures a year soon. I want to highlight that this is a bit of an old data now, but the next largest program as of last year was about 50 cases per year. And so in Kingston, we're performing more than 3 times the number of cases of colorectal procedures for cancer than other centers across Canada, which would include places in Toronto and Montreal, Ottawa, Vancouver, etc. So much bigger cities with bigger hospitals are still not keeping up to the type of robotic surgery that we're able to, the numbers in terms of what we're able to perform here. And I think that's a real advantage to being in Kingston, is that we have such great support from everyone involved to really expand and use the robot when we can. One of our main motivations, as I mentioned earlier, was to improve the minimally invasive surgical rates and reducing our conversions. So in 2019, when we first started robotic surgery, we really improved our rates of minimally invasive surgery. So our conversions dropped dramatically. Our use of open surgery often also dropped, and more than 80% were now starting and completing a successful minimally invasive surgery, and most of these were robotic. As we've gained expertise, the conversion rates have dropped even further, and the number of open procedures has really dropped. And now we're more than 94, 95% of patients being eligible and completing a minimally invasive approach, which is a huge change from where we were about 10 years ago when we had access to only open and laparoscopic surgery. In terms of conversion rate, so these are people that you start minimally invasively and cannot complete safely that way and have to convert. We were about 1 in 4 conversions before 2018, and over the last couple of years, we're well under 5%. And I think what this represents is that although the case's complexity may be about the same, we do not need to convert to bigger incision because we can provide complex minimally invasive surgery in a very safe way and can continue to persist and give patients all the advantages of minimally invasive surgery. This is the graph that I showed earlier that showed where we were in 2018. And right now in 2023, with a bit of updated data, we're sitting right at the top. There is no hospital in Ontario that performs a higher proportion of their surgeries minimally invasively for rectal cancer. We're an absolute leader in that regard, and I think that's proven to be hugely beneficial to our patient population. Some of the other outcomes that we all have been monitoring since day one is the return to the emergency department. Again, a very distressing part of potentially patients' care. We have dropped this by about 10%. This is still a high needs patient population, so there's still issues that require people to come back. And our readmission rates haven't dropped dramatically. In fact, they increased a little bit, but I think this is just a bit of variation. One thing that has been very dramatically different is our length of stay. You can see for rectal cancer patients, our median length of stay is now 3 days, whereas before it was 6 days. And correspondingly, our average length of stay has dropped about 4 days. And again, this is an absolute outlier in the province. The average length of stay across the province is around 7 days for a rectal cancer surgery, and you can see that we've dropped dramatically below that level. One thing that we've been especially cognizant of is the cost of care. We recognize that we are working in a situation with limited resource, and we want to make sure that we continue to offer surgical care that wasn't hugely more expensive than previous. We had data on our 2 years prior to implementing robotics, where the average cost of care for this patient population was just over $15,000. And we see that in 23, 24, the average cost of care has increased a bit by about $400. But we think that the benefits to the patients and the overall benefits to the quality of life, well-being, and recovery is worth the extra $400. Interestingly enough, Cancer Care Ontario provides case-based funding. And so for each case that the hospital completes, they receive about $14,500. And so we were a bit over that before, and now we're a bit more over it. But what's really interesting is that the province has recognized the importance of robotic surgery. And there's been discussions, and I think that this is going to come through probably after the next election, to add a bonus for people doing, or for hospitals doing robotic surgery. So there's going to be a $2,000 supplement if you can offer robotic surgery to try to offset some of the cost increases that we expect. So this would bring the case-based funding up to about $16,500. Which now I think kind of represents a real opportunity for our hospital. We previously had a deficit of about $550 per case, and now we have a potential revenue of maybe $1,000 based on these new funding models, which could be reinvested in our program or other programs as well. So I think that this is an interesting and positive outcome from our work. I do sit on the one of the provincial committees that has been discussing robotic funding and how it should be allocated. So I think the province is very keen to recognize the benefits of robotic surgery, even though it can be a bit more costly. In terms of expanding our MIS capabilities, this was another goal of ours, and we really wanted to put Kingston on the map for this. With robotic surgery and our ability to work very well with our colleagues in urology, gynecology, and thoracics, we were able to do a number of Canadian firsts, which we're very proud of. So myself and Dr. George Gray performed the first combined robotic rectal resection hysterectomy. That had not occurred beforehand, and I think it speaks to how collaborative we are between our surgical groups and the access of the robot. We were also able to do the first combined robotic colon resection and partial nephrectomy. I did this with one of the urologists. And again, this is a patient that would have needed potentially 2 different surgeries, or a robotic and an open surgery, or 2 laparoscopic surgeries. And we were able to combine this to allow the patient to have 1 surgery and have a really nice recovery from that. We performed the first combined robotic rectal resection and laparoscopic liver resection. As I mentioned previously, patients with rectal cancer may have cancer spread to other organs and may need surgery at the same time. And we were able to offer patients that. And then finally, which is relatively new within the last week or 2, we've combined and done the first robotic sigmoid resection and cholecystectomy. And this is a picture from that day with myself and Dr. Sean Bennett, who's a hepatobiliary surgeon that's had sought out extra training in robotics. And we were able to do this. And although cholecystectomies, routine cholecystectomies, probably will never be done robotically, we thought it was a great benefit that we could offer a patient both robotic procedures, as we were already using the tool for the sigmoid issue that I was dealing with. The other advantage of this is Dr. Bennett's has pursued additional training in doing robotic liver resections, which is a procedure we see has a lot of benefit to patients if we can combine our robotic colorectal cancer surgeries with the robotic liver cancer resections. The other impact that we've really embraced and are very proud of is on mentorship and training. Kingston Health Sciences Center is now recognized as one of the premier places for robotic surgery, especially colorectal surgery. And we've been able to train surgical fellows who come to our hospital to go back and train or to offer robotic surgery elsewhere. So our first surgical fellow is Romina Bianchi, who's now a robotic surgeon in Argentina and has been tasked with teaching the academic academic surgeons in their largest academic center robotic surgery. Katrina Knight's in the middle. She's our current robotic fellow, and we'll be taking the skills step back to Glasgow in Scotland and really expanding the robotic programs there. On the right is John Soares, who's now in Barrie. And when he came to work with us, it was more as a opportunity to see new technology, not necessarily thinking that he'd be offering robotic surgery early in his career. But I understand that Barrie is in the process of rolling out a robotic colorectal program. So he'll be the one that will be leading that. We've also had a number of surgeons from other institutions, such as University of Montreal, London Health Sciences Centre, Sudbury, Jewish General, and Dalhousie, either visit with us or interact with us to have us mentor them in rolling out their programs. And this has all been in the last couple of years. So there's been a huge increase in interest from surgeons and colleagues to try to expand and initiate their robotic programs. I think the other thing that we're really proud of is the impact locally. So Kingston and in the Southeast region. I cut away some of our own local articles, as well as one that appeared in the Wake Standard that just describes how the impacts have changed our patients' lives in our region. And I think this is really why we do robotic surgery, why we try to enhance our skills and adopt new technologies. We really want our patients to have the best treatments they possibly can. And we think that that's now being done in Kingston. I put in the bottom left the Ontario Surgical Quality Improvement Network. At a provincial level, when they looked at our data across the province and comparing hospital data and outcomes, they identified colorectal surgery at Kingston as an absolute outlier in terms of positive outcomes. So I went and spoke to the Ontario group about what we were doing well and why we were having such short length of stays, low complication risks, and other major benefits to the program. And one of the things I really highlighted was the robotic platform as something that's been hugely beneficial for us. I really want to recognize that this is a team effort. Often, as a surgeon, I get a lot of credit for the robotic program, but I think it's really important to highlight just the dedication of our nursing staff in making sure that the robotic surgeries go off without an issue. They went up above and beyond to get extra training and technology that they weren't sure was going to be really game changing because they were less familiar with it, but have really embraced it. And I think without their hard work and dedication, a lot of this would not have been possible. I would also say I'd like to thank our department heads, our hospital executive, our administration for really supporting the robotic program and really being in line with our vision of trying to offer robotic surgery to anyone that's eligible based on the benefit that we see. And I just wanted to leave off with kind of some final thoughts. Robotic surgery in Kingston Health Sciences Center has been extremely successful. We have a colorectal program, our program that we think is one of the best in the country, if not the best. We also have a really solid urology program, gynae oncology program, and thoracics program. What's very unique about Kingston Health Sciences Center is that in many different hospitals, only one or two services tend to have access to the robot. And whether that's internal politics or volumes or whatnot, I'm not sure, but we would be one of the few hospitals that offers 4 specialties doing robotic surgery. And our vision is really to expand that beyond this. I had spoken about hepatobiliary surgeons becoming robotic surgeons. There's great need for that. There's great need for other abdominal surgeons to get onto robotic surgery, which includes the upper GI and bariatric surgeons, our cardiac surgeons, and there's still room for growth, and especially in lung cancer surgery, where only half of our patients that are eligible for robotic surgery are able to get robotic surgery. And I think this is one of the reasons why the foundation and others have made a huge push to try to acquire a second robot, because we really strongly believe, and I'm really supportive of trying to offer all advanced minimally invasive surgery as robotic surgery. I do think that's the future, and I think Kingston Health Sciences Center is really well positioned to be a leader in this regard. So I think that's the end of my slides. I'll stop sharing, and I'd be happy to take any questions that anyone may have, whether that's through the chat or if someone wants to speak up. So I'll just defer. Thank you.
So we do have a couple of questions. The first one is, how do infection rates compare with open or laparoscopic surgeries?
So that's a really great question. So in colorectal surgery specifically, historically, the infection rates were 20% or more. So one in 5 patients would have a major wound infection or other infection. Because our incisions are so much smaller, our infection rates have actually dropped to less than 5%. When I began about 10 years ago, it would not be unusual to every week have someone that had a wound infection on the floor from one of our procedures. Now it's an absolute exception. So our wound infection rate has dropped to less than 5%. And in fact, we have trouble tracking it sometimes now because it's so low. So this is a major benefit for minimally invasive surgery just in general, is that the wounds are so much smaller, you protect them, and you don't have everything exposed to the air and potentially contamination during the case. So there's a huge benefit from that standpoint.
Next question is, what's next for the robotic program? Are you looking to expand to more types of surgeries and patients?
Yes, exactly. So we see a lot of growth in several different domains. So as I mentioned, hepatobiliary surgery can be very complex. This is liver surgery, bile duct surgery, pancreas surgery. A lot of the surgery there is done open because the complexity of the surgery really precludes it from doing typical laparoscopic surgery. We think that there's a lot of growth there. We also think that there's a lot of growth in upper GI surgery. So this would be surgery on the stomach and in the form of things like weight loss surgery, which is largely done laparoscopically, but complex weight loss surgery is probably beneficial to do it robotically. Hernia surgery is another domain that tends to be done open, that we think that there's a lot of potential for growth. I mentioned lung surgery. Right now, we're doing about half, I think, our eligible cases robotically, and I think our lung surgeons really want to be able to offer this to everyone. Cardiac surgery has been at the forefront. That's something that I think we really want to roll out. I know that the Department of Surgery has done a lot of work in hiring robotic trained surgeons to try to roll out a cardiac program with the benefits as well. So I think that those are a lot of the growth areas. I see robotic surgery eventually just replacing laparoscopic surgery. So I see eventually that anything that we're doing laparoscopically will probably be done robotically in some form or another, whether it's this type of robotic platform or different ones. But I really see that there's a lot of growth both in the short and long term.
What is the capital investment required for each machine?
um, don't quote me on this. I'd probably have to defer to the foundation or others that interact. But I think in general, it's in the $3.5 million range. Although it's can be different based on different purchasing options and whatnot. But that's the general range that we're looking at.
There's a couple of questions around how do you decide which patient gets robotic procedures and which patients need an open or laparoscopic procedure? And secondary to that, is there a wait list for robotics?
Yeah, so I'll speak to the colorectal program. So for colorectal surgery, our default is robotic surgery. So every patient we see in consent for a major colon or rectal resection will by default be likely selected for robotic surgery. There's some very specific patient factors that may preclude it. Large hernias, maybe some other abdominal wall issues where we can't dock the robot, or if someone has significant scar tissue from previous surgery, it may not be possible to even dock the robot. Those are very low proportion of our patients. There's some very specific presentations of cancer that generally require an open operation. So if the rectal cancer is invading the bladder and the prostate, to remove the bladder and prostate and do reconstruction, that tends to always be done open. That is a very small proportion of our patients. So in general, about 95% of our colorectal patients are offered and are eligible for robotic surgery. We don't triage it, meaning we don't say it's good for this patient, but this patient, although we could do it, we can't. We tend to just offer it to everyone. Our wait times for cancer surgery usually run in about the 4-week range from decision to operate to surgery, just because there's a bit more urgency. Our larger surgeries for benign disease like Crohn's disease or diverticular disease, the wait time can be a lot longer, 6 months, year, maybe longer in some cases. I don't have a good sense of that right now because a lot of things have changed over the last couple of months, but that's generally the wait list.
Somebody is asking, does the robot save staff in the operating room?
Does the what, sorry?
Does the robot save staff in the operating room?
No, I think from that standpoint, I think it's regardless of whether it's robot, lap, open, there would be the same number of nurses, the same anesthesiologists, the same number of people on the surgical team. So it doesn't really impact that. Sometimes we'll have like the tech people involved to help us make sure we're not going to run into troubles from the technology standpoint. That would be the only additional person that may be involved in a robotic case that wouldn't be involved in open, but they tend to be available for other technical issues as well with other techniques.
And are there any negatives? Is it possible to miss something?
It's not that we would miss something. The robotic platform, just by the nature of it, how it gets fixed to the patient, you can't move the bed once and reposition the patient once the robot is docked, which does have some implications for us when we're working in the abdomen. If we're working the pelvis, we usually tip patients head down so that all the small bowel and everything retract out of the pelvis. Whereas if we want to move to the upper abdomen, we usually put them head up. So that is a little bit more challenging robotically. We can overcome it by undocking the robot and then redocking it. But that position change and kind of moving from quadrant to quadrant can be a little bit more challenging. It's not quite as flexible as open or laparoscopic surgery.
One of our donors wants to congratulate you on your accomplishments. And he says the Da Vinci predates the explosion of AI. Is there research happening into incorporating AI into the Da Vinci robot?
Yes. So the Da Vinci that we have is about a 10-year-old technology, or maybe an 8 or 10-year-old technology. The company that created the Da Vinci has just released what they call the Da Vinci 5, which I think was released just this past year in the US. Is not yet Health Canada approved, but will probably be here in the next year or two. And that incorporates more AI into the work. There's been a lot of thoughts on how you can incorporate it to enhance your capabilities. So for instance, having AI identify anatomy that sometimes is hard to identify, predicting kind of where the next cut should be. There's some thoughts about how using it to have kind of what they call fly and no fly zones. So areas that we know would be dangerous to be operating versus not. This is the type of technology that people are developing. In terms of the DV5, I know there's AI involved with it, but I'm not sure that it's meant to give feedback in the moment, more so to allow you to do video reviews and have you kind of understand and see where the challenging cases are and for quality improvement. And I think it allows us to just get more data from our procedures to know what we're doing well, what we need to improve upon. I'm really, I think, excited to see how the AI is being included in the DaVinci 5 because we don't have access to a model right now. And ours is, as I say, about 10 years old. So I think that will be heavily incorporated for sure.
What about software glitches and or power surges, outages during surgery?
So power surges, I don't think are an issue. I think the OR is a relatively protected place from that standpoint. So we don't have any kind of power issues necessarily. Software and interface with the hardware, sometimes we do get error messages. So just how an arm is docked or how an instrument is placed. Often it's just a matter of pressing a button. There's kind of error messages that say, you know, there's a yellow error on this thing, press this button to resolve, and it will resolve it. Worst case scenario, we power down and power up again. That would almost never happen while we're actually operating. It's usually when the robot is first being fired up and we're connecting all the instruments to it. So we have not had a failure while operating, but beforehand, we occasionally have to power down and power up again just so it can reset itself and the arms will move how we want or whatever. So that can happen from time to time, but usually it's easily resolved.
Do you think that robotics could ever be used for eye surgery?
I don't know. I think that's a great question. I'm unfamiliar with eye surgery. I know the ophthalmologists are very talented and they work in very small spaces and use microscopes to do their work. When we work with the robotic surgery, we have a camera that has a 10 times zoom and I can damper down my movements to like 5:1 or 10:1. So I can make maneuvers in millimeters of space with the robotic platform. So I'm certain that that would have benefit to the eye surgeons. I wouldn't know. I don't have a good flavor of where they're at from robotic surgery versus kind of continuing on with the current techniques. But I can't see why it wouldn't be eventually applicable to them as well.
And finally, where would a physician go to receive training to operate the robotics machine?
Yeah, so there's a number of pathways. So I did robotics in my fellowship. So there's a lot of fellowships, especially in the US, that are offering robotic training. And as I mentioned, we do that as well. So if there's a Canadian that wants to do robotic colorectal surgery and wants to go through a fellowship, which is 12 months of training, they would come to us and they would learn from us. If you're a surgeon already in practice, which is what Dr. McDonald, who's my partner, was at the time, there's a training pathway. Interestingly enough, the robotic consoles have a simulator on it. And the simulator basically takes you through all the functions of the robot, how to move the instruments, how to move the camera, how to do this, that, or the other thing, and is really high fidelity. And so when we go through the training pathways, there's a period of time where you have to work on the simulator. There's hundreds of exercises and you need to reach certain scores to move on to the next exercise. So you have to go through that pathway. There's then courses at the Intuitive Training Center in Atlanta or through other organizations like the Society of, it's called SAGES, the Society of Gastroendoscopic Surgery, that offers courses that you would go down for 2 days, 5 days, 7 days and do courses and just work over and over again on the instrumentation. There's then a mentorship period where once you come back, you've gone through the simulator and the courses, there's a mentorship period where robotic trained surgeons will support you for your cases to make sure that you understand kind of the technology, the instrumentation. When surgeons that are in practice go out and get this training, it's not that they don't know how to do the procedure, they just don't know how to use that technology to do the procedure. They already know how to do it laparoscopic or open. And so it's just training to use the instrumentation. And that's kind of that pathway. So I think the future will be most people will just get their training in residency or in fellowship. But right now, definitely there's going to be a period of time of training established surgeons in robotics through that type of post-practice pathway.
How many hours per week is the Da Vinci being used right now?
So it's used 5 days a week. So we have 5 days of elective operating time per week, so Monday to Friday. At KHSC, elective time is either in 7.5 hour days or 10-hour days. So either from 7:45 to 3:30 or from 7:45 to 6 p.m. The majority of robotic rooms are 10 hours. So up to 50 hours a week of robot. And we right now are at full capacity, meaning that it would be rare that there isn't a day, or there'd be a rare that there'd be a day that the robot isn't used. And so that's really, again, why we're trying to expand to try to get a second platform to really open up and double our capacity for procedures. There's some talk about trying to do emergent surgery on the nights and weekends. That's another bridge to cross. I think definitely for us, we have emergency presentations of colon cancer that right now, those are the ones that we tend to do open and laparoscopic because the training of nurses on the weekend is different than the ones that work with us every day in the robotics room. And right now, I think we just really have to think about how we would incorporate that emergently. But I think that's also on the horizon. So stay tuned for that one.
Who pays for the training that you mentioned before?
So I think it's a combination. There's courses so Dr. Bennett went to a course in France, which is world renowned, which I think was a 1 or 2 week course. And CMO, which is our organization that funds physician, paid for that. He put in a grant application to be funded for that because it can be very expensive. So those types of courses, either your hospital or your organization have to pay for through independent organizations. There's also the Intuitive training courses, which Intuitive is the company that makes the robot. So they have training centers to obviously to encourage the use and support surgeons. That would be funded by Intuitive. The simulation practice, et cetera, as long as your hospital has a simulator, you don't need to pay for that. You just need to invest with your time, which is usually after hours and on the weekends.
Is there a technology transition team?
I guess I would need to know what that means to the person that asked that. There's certainly team, yeah.
So he says, I'm thinking fewer open surgeons available.
Oh, I see. Yeah, there's been a concern about that for quite some time, actually. So transitioning from different techniques, so from open surgery to laparoscopic surgery to robotic surgery, do you lose that skill set and can you no longer do the kind of traditional way to do things? The reality is I don't think that that's actually proven to be true. We just get much, much better at the new technology. A classic example is gallbladder surgery. Prior to the mid 1990s, everyone had open gallbladder surgery. There was a transition between probably mid 90s to mid 2000s where it went from like less than 5% of people getting a laparoscopic cholecystectomy to less than 5% of people getting open cholecystectomy. There's been concerns that surgeons have lost that skill set to do open cholecystectomy. And that could potentially lead to other problems. I don't think that we've actually seen that in the data. We just get better at doing laparoscopic surgery. So the things that people had struggled with early on in their careers doing laparoscopically, they no longer struggle in. So there is always that concern. Do you lose the ability to do the more traditional techniques? But I think we'd have to still really see where that plays out. Because I still have to do open surgery from time to time. And I feel like doing a lot of robotic surgery hasn't affected my ability to do so.
You mentioned previously that the robot is about 10 years old. What is the life expectancy for it? And do they continuously get software updates?
Yeah, so the robot we're using is about 10 years old, but we've had ours for about 8 years. And I think they generally would label the lifespan as about 10 years, although I've seen some institutions that have had and have used the same model for up to 15 years. But at around the 10-year mark, really you want to, I think, update. It's more of a hardware issue. The software updates happen continuously, but the instrumentations change. And as they come out with new generations of robots, just like your new iPhone doesn't plug into your old iPhone jack, the instrumentation starts to change. So although the instrumentation is improving, it's not compatible with the older models. And so that's what we saw with the previous transition. And that's what I think we're eventually going to see. So I think our current robot does a really great job, but it's probably due for upgrade in 2028. So I guess it's about 7 years old here. So it's due for upgrade in about 2028.
Well, thank you very much, Dr. Patel, for taking the time to join us today and for answering all these questions. There's obviously a lot of interest in this subject. And your presentation just really shows us how truly lucky we are to be here in Kingston and to have such cutting edge surgeries available to us here. And so we're very grateful for that, and thank you. This video will be available on our website and YouTube channel tomorrow, so feel free to share it with your friends and family. You will get an email tomorrow afternoon with that link for you. Don't forget to play the UHKF 50/50 lottery. This month's jackpot deadline is at 11:59 tonight, and the jackpot's almost at 18,000. The next Circle of Care event is an in-person luncheon that will take place in June. Dr. Susan Crocker will be talking about exciting advances that are being made with genomics in the KHSC labs. Look for your invitation to come in May. I hope to see many of you there. Enjoy the rest of your afternoon. Don't forget to vote, and thanks again for joining us.